Okay. Good morning, and thank you for joining us. My name is Pam Clark-Reidenbach, and I'm the Executive Director of the Northern Illinois Center for Nonprofit Excellence, also known as NICNE. Today's training session and two additional to follow are provided to you through the Youth Mental Health System of Care, which is a variety of youth-serving providers and parents of children with lived experience, working to build a comprehensive, high-quality mental health system that is affordable, equitable, and accessible to all. The design of the system of care, including these trainings, are made possible by a grant from the Children's Healthcare Foundation. The trainings are the start of a community of practice for youth serving mental health providers. After today's session, you'll receive additional information on how you can get engaged in the system of care, but don't hesitate to reach out to me or to Billy from NICNE and any of the current members of the system of care to learn more. So it is now my pleasure to introduce our trainer for today's session. Jessica Gregg is a therapist and clinical supervisor with Children's Home and Aid through the Child Welfare Clinical Services Program. Jessica has worked in the mental health field with children in foster care and high-risk youth with 9 years of postgraduate experience. She is a licensed clinical social worker in the state of Illinois with an MSW from the University of Denver. Jessica's professional areas of focus are childhood trauma and its impact on mental health treatment needs, and the experiences of children and families involved in the child welfare system while providing supervision and trauma-focused therapy. Jessica is certified in trauma-focused cognitive behavioral therapy, is a rostered therapist for the child parent psychotherapy model for younger children who have experienced trauma, and is foundationally certified in TheraPlay. Jessica is the agency co-chair for the Regional Trauma Initiative Committee and is a member of the Children's Home and Aid statewide implementation team to establish the attachment regulation competency framework to become a trauma-informed agency and ensure that those who have experienced trauma receive effective treatment. As a trainer, Jessica provides basic trauma training throughout the Rockford region and provides additional training on diagnosing and treating complex childhood trauma. We are so pleased to have her with us today. Please welcome Jessica Gregg.
Good morning, everyone. So I am going to share my screen, I believe. I can still do that. Okay, good morning, everyone. I'm so excited to have so many of you here. Hopefully, I'm able to continue to work the technology, and I am hoping to keep the chat box open as I'm able to. And wow, good morning from the UK. That's so exciting. Thank you so much, everyone, for being here. This is one of my passions, and I'm so excited to share all of this with you. So I am a therapist and a clinical supervisor with Children's Home and Aid, specifically in our Child Welfare Clinical Services Program. As mentioned, I have a lot of trainings in specialized treatments for trauma. And then personally, I also want to note that I am also a foster parent with a local agency here in Illinois. And I just think that's important because I feel that my personal and my professional life has really informed each other. And I don't have any other disclosures to make. These are some of the training objectives that I have for us today. I do want to really acknowledge that this is a very condensed training. Truthfully, half of these slides I could talk about all day, and hopefully this will be an ongoing discussion that we're able to have and that we're having in the field. So please bear with me. I do know that it is a lot of information, and we're really touching on the surface of a lot of it, but hopefully this is enough at the very least to help everyone have some big takeaways and go back and work on creating their own trauma-informed systems of care. So primary objectives are to increase the understanding of the presentation of traumatic stress and developmental trauma for children, overview some mental health diagnoses relating to trauma, discuss the challenges of diagnosing complex trauma specifically for children. Look at the difference between traditional treatment approaches and a more trauma-informed paradigm for treatment. We're also going to really talk about some key components to creating a trauma-informed system of care. And we're also going to talk about some common evidence-based treatment. That's a big piece of things. And also acknowledge that there are some barriers to establishing trauma-informed care. I am going to try to have the chat box open, like I said. If you are able to ask any questions in the chat, I do have somebody, oh, Billy just commented in there. She's going to be helping to monitor any questions. You can also raise your hand using that Zoom feature. Oh my gosh, hello from India. Wow, what a thrill this is this morning. Thank you, everyone. Also, I did want to note there might be some opportunity for case discussions. I have a case example that's a hypothetical that I put into our presentation. If you share anything about your own personal experience, please remember to maintain confidentiality. Don't give out any identifying information for that. Okay, so to begin, I would really love to hear what everyone, well, I guess we've got quite a few people, so not everyone, but a few people, what you're bringing with you today to this training. How familiar are you with the concept of trauma, with childhood trauma more specifically? Oh, good morning from Michigan. I'm originally from Michigan. How familiar are you with trauma-informed care? How might you define it? And do you feel you are currently providing trauma-informed care? Oh my gosh, Ecuador, wow. That's so exciting. So I don't know, I don't know if I can tell if anybody's raising their hands, but if anyone could go ahead and type their thoughts into the chat, I would love to hear. Malaysia, wow. Thank you everyone for sharing where you're coming from as well. That's really exciting. I love the idea of this trauma-informed care kind of sweeping the globe.
One person that shares they provide trauma-informed care as an OT in school.
Oh, OT, great.
The CBT trauma-focused services training.
Humanistic, okay.
Certified peer recovery coach.
Okay, recognizing trauma impacts every aspect of a person's life, absolutely. Okay, wanting to learn more. Oh, juvenile court. There is a heavy population with a lot of childhood trauma. Okay, sexual assault agency, absolutely.
Yeah, some people that are also new to the concept and are looking forward to learning.
Yeah, wonderful. Oh, another juvenile court. Okay, substance abuse, CASA, homelessness intervention. So a lot of people, domestic violence. Okay, the ACEs, great. Adoptions agency. Okay, somebody else with TFCBT, first responders. Okay, wonderful. Thank you so much, everyone, for sharing your experiences. Okay, oh, play therapist. I really appreciate everyone sharing. That's really helpful to know where everyone is coming from and what everybody is bringing into this training. So I am gonna exit out of the chat actually. It is blocking some of my screen. So Billy, if you wouldn't mind chiming in, if you notice any questions, that would be great.
Absolutely.
Okay, so in order to talk about trauma-informed care, we need to have a working definition of what trauma is. So there is the traditional concepts of trauma and the definition. I have that first main definition from SAMHSA, the Substance Abuse and Mental Health group from the United States. So that is, I will say also, I didn't expect it to be so international, but everything that we're working out of here, I do want to acknowledge is culturally based in the United States. So there are likely to be some differences moving forward for your own practice. But these are the definitions that we'll be using for today. So trauma or traumatic stress results from an event, series of events, or circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening and has lasting adverse effects on the individual. The DSM defines that as exposure to actual or threatened death, serious injury, or sexual violence in one or more of the following ways: direct experience, witnessing, learning about an event, or experiencing repeated exposures. So again, that's a very clinical, very broad kind of grasp of trauma. I've also heard trauma described as anything that overwhelms an individual's ability to cope. I think that's a really good demonstration of trauma. And then as we're talking about trauma, there are some ways to describe trauma as a spectrum. Some people might conceptualize it as small t and large t traumas. Large T traumas would be sort of the classic examples of trauma. Complex, chronic, or acute traumas that are really big. Child abuse, physical abuse, sexual abuse, community violence, or war. Those are the bigger items that are easily identifiable as a traumatic event. But what's still very, very important are those small t traumas, those life events that are very upsetting. You may not initially identify them as traumatic, but especially for children, they really truly are traumatic and have a very pervasive impact still. So attachment trauma, neglect, having family systems of substance use or mental illness, all of these things add traumatic stress into a child's life. And that's important as we're specifically thinking about treating children today. When you're talking about trauma, you do want to remember to keep in mind the individual's experience. What might be a large T trauma to one person may be a small t trauma to another person. But the important thing is to really recognize that it has been a source of traumatic stress for that individual. And the goal as we move forward is to really have a comprehensive understanding of what an individual's experience has been and any potential sources of traumatic stress for them. These are the current trauma diagnoses that were established and portioned into a separate diagnostic criteria in the DSM-V. Disinhibited social engagement disorder, reactive attachment disorder, acute stress disorder, adjustment disorder, and post-traumatic stress disorder. PTSD in particular now has distinctions and diagnostic criteria for children and pediatric presentations. Some of these are very common. You may have worked with children, for example, with reactive attachment disorder or an adjustment disorder. We're not really going to get into those different diagnoses. Again, trauma diagnoses on its own could be an entirely separate conversation. But I just want to highlight these trauma diagnoses because in order to be treating trauma, in order to be establishing a system of care around trauma and those diagnoses, these are some of those diagnoses you would typically see. Unfortunately, there was a proposed diagnosis that we'll talk about in a minute, the developmental trauma disorder diagnosis, and it was not accepted into the DSM-V. And that leaves a really significant gap in treating children with complex or developmental trauma. And that's really going to be a big focus of this training. The challenges of those diagnoses that I just mentioned is quite a long list, unfortunately, particularly when working with children. Depending on your setting, you may not be able to do the comprehensive psychosocial assessment that's really needed based on current diagnostic criteria to gather the sufficient historical information in order to diagnose. PTSD in particular, you may not have a full history available depending on your role. The child may not be able to disclose their history or disclose sufficient symptomology to meet diagnostic criteria. And we know that the DSM-V has very specific criteria. Insurance companies want to see certain codes, and that's a big challenge. And so how do you treat and identify a child that you know has experienced trauma, but maybe doesn't fit what's currently established? Developmental trauma, again, we're going to be speaking a lot about that today. It's really not well represented with the diagnostic criteria. There's a heavy emphasis on kind of pathology, right? We've pathologized trauma and trauma presentation, but that doesn't really indicate the impact that trauma has, particularly for children. Children placed in foster care, for example, often have significant trauma symptoms, attachment disorders, or insecure attachment styles, and that is just simply not fully met by a single trauma-related diagnosis as they currently stand. Then you also get to the overdiagnosis of things such as ADHD or behavioral disorders. And this is a quote from Dr. Bruce Perry in this book, The Boy Who Was Raised as a Dog. This is referenced at the end of the presentation, and this I would highly recommend as a resource, by the way. He mentions in his book, while not all ADD, hyperactivity, and oppositional defiant disorders are trauma-related, it is likely that the symptoms that lead to these diagnoses are trauma-related more often than anyone has begun to suspect. And that was 2006. That's quite a while ago when we think of and conceptualize our understanding of trauma and our treatment of trauma as well. So it was indicated at that time that those disorders may be overdiagnosed, and yet we're still here moving forward trying to really identify how can we best diagnose and identify these children that have experienced trauma. I guess I'll pause really quickly. Billy, any questions in the chat?
No questions yet.
Great. Okay. So now we'll talk about complex trauma, and what do I mean by that? This is an understanding developed from the work of clinicians such as Bessel van der Kolk and Dr. Bruce Perry. Of course, they are not the only clinicians working on these concepts, but for me professionally, their work has been significantly influential, and a lot of the information in this presentation is sourced directly from their work. So I do highly recommend both of those for ongoing resources for your own development as well. Bessel van der Kolk is the one who had a team that submitted a proposal to formally include developmental trauma disorder as a diagnosis in the DSM. And this is a diagnosis that would provide a comprehensive presentation of the impact of early complex trauma on child's development. This is his quote here. The traumatic stress field has adopted the term complex trauma to describe the experience of multiple, chronic, and prolonged developmentally adverse traumatic events, most often of an interpersonal nature, such as sexual or physical abuse, war, community violence, and early life onset. These exposures often occur within the child's caregiving system and include physical, emotional, and educational neglect and child maltreatment beginning in early childhood. This is a really important distinction in place because when we typically talk about trauma, there is the conceptualization of across the lifespan, of the acute impact on a moment in somebody's life as well. But when we're specifically talking about children, we are talking about somebody who is still developing, still learning and growing and learning about the world. And they are doing all of that then within the context of complex trauma. And that has a significant impact on their development and then on their functioning. And that's really missed in the current diagnostic criteria. This is some more information about what developmental trauma truly looks like. There are symptoms and features from those other traditional diagnoses associated with trauma: hyperarousal, hyperactivity, the flashbacks, the dissociations. That is still included in developmental trauma, but it's also a much more comprehensive representation. Developmental trauma recognizes that there's insecure attachment patterns that develop and specifically looks at then the impact of the lack of a secure attachment figure for children and their subsequent development. Where with developmental trauma, children are unlikely to develop a sense that the external environment is able to provide relief, is a safe space. They cannot rely on others to help them. And we know from children from healthy development that children need to learn how to regulate their emotions within the context of their safe, secure relationships. Children may experience excessive emotions, anxiety, anger, longing to be taken care of, right? That might drive some attention seeking, some very maladaptive behaviors. Children may also engage in self-defeating aggression. Children may space out, learn to ignore what they feel or what they perceive, because they've learned the world around them is not safe. So any of their own responses to the world may similarly be unsafe. Significant developmental milestones are also missed when developmental trauma occurs, and any subsequent development is seriously hindered by that complex trauma, particularly when it occurs. So why are we considering it? Why do we need to talk about developmental trauma? When we're specifically looking at children, we need to recognize that the current diagnostic criteria, the current understanding of trauma does not represent what these children truly go through. Complex trauma, developmental trauma has an impact on the child at the time, from the time that it occurs and onward. We need to really look at these children in terms of the context of the age that the trauma occurred, because any subsequent development is impacted. Dr. Bruce Perry in particular has done significant work looking at the neurodevelopment of children, and he's learned that areas of the brain may be over or underdeveloped due to trauma. There's also his concept of biological relativity, meaning that a child's brain is more susceptible to developmental trauma during times of rapid change. So not only do we need to make sure that we have an understanding of the traumas that occurred for a child, but we also need to know when those trauma occurred. What was occurring in that child's life? Did they have any mitigating protective factors? And what developmental stage were they at? Any developmental insult or injury is going to have an adverse impact on all subsequent development, which is, again, why we need to be considering developmental trauma. We cannot look at an event as acute the way that we might for an adult. It is acute, perhaps, in a child's life in that sense of that incident, but it has ongoing impact because it remains. It is a very pervasive impact because they're continuing to develop. I really like Dr. Vanderkolk's quote here: when children are unable to achieve a sense of control and stability, they become helpless. If they are unable to grasp what is going on and unable to do anything about it or change it, they go from immediately fearful to a stress response, that fight, flight, or freeze response, without being able to learn from the experience. I really like that quote because I think it really demonstrates very well what Dr. Bruce Perry is talking about with that sequential process to development. If they experience a significant trauma, they're going to have significant impact and they cannot learn from it. And what do we know about trauma? Trauma exposures. They continue to re-experience those traumatic experiences. They continue to have trauma responses, and each time it is reinforced when we do not appropriately respond, and then they continue to move through their development with active trauma responses. That's very, very different from the current understanding, or diagnostic understanding rather, of trauma. The other piece that I really want to note is that the concept of developmental trauma really allows for the consideration of additional source of traumatic stress that the current diagnostic criteria does not include. Significant impact of historical, cultural, and racial traumas cannot be ignored or dismissed, but there's not a space for that consideration in the current diagnostic criteria. So we really need to have something to allow for conversation and an understanding of really a comprehensive look of what this child's life has been like and what they're bringing into our space, depending on our role that we are working with them. So this is a space that I want to pause now, and I'd really love to hear any questions about what we've talked about the concept of developmental trauma, any challenges that you maybe have faced in identifying or diagnosing trauma, and any questions that you have relating to the definitions that I provided. And again, I know it is challenging, right? We're kind of working with a concept that is not strictly included in the DSM-V, but that concept of developmental trauma, that's really what I want everyone to keep in their forefront of their mind as we're moving forward and talking about treatment and a system of care. So it looks like Derek Lewis has clients. Okay, let me read that. Children. Oh gosh. That is a really, really difficult parental alienation and the coaching and victimization. That's, gosh, that could be a training on their own. My play therapist supervisor actually, in one of my recent supervisions, had mentioned a resource specifically for that. And I don't know that I can think of it at the top of my head. That's a great question. I would absolutely recommend seeking additional supervision on that case. If I can remember it, I will put that in the chat later. The link between developmental trauma and disorganized insecure attachment. Absolutely. So a really great example of that is a toddler. So in typical healthy development, a toddler will go about and learn to explore their world, right? They're going to fall, they're going to tumble because they're toddlers and they don't understand, that there's limitations to their world. They're just learning they can do things on their own, which is part of why, we call it the terrible twos, because they learn they can do things on their own, but there's also quite a lot they're not allowed to do, right? So they're going about their toddler selves and they fall, right? That's going to happen. So in a typical healthy development, right, we would recommend that the parents not panic, even though I have a toddler currently, he makes me panic all the time, but we try not to panic, right? We want to teach our child that it's okay. They sprained they scraped their knee. It's okay, they can survive that. It feels really scary, but by our own regulation, our co-regulation with the child, we teach them that this is okay, this is survivable. And then they learn, oh, I am fine. This is fine. I can go back out into the world and be safe. Unfortunately, with developmental trauma, whether or not they have well, it does matter if they have a secure figure who can mitigate some of that. But think of a toddler going out into the world and either being actively injured by a caregiver, whether it's directly by abuse or by exposure to violence, such as domestic violence, neglect, insufficient supervision. They may go out, scrape their knee. Nobody teaches them that they can be okay. Nobody teaches them that they're able to survive this and that somebody else will help mitigate some of the scary, hard feelings for them. And so they do not learn that they can be comforted by a secure adult. And that's really important. They need at least one secure attachment figure to then teach them that the world can be safe and use that for their foundation to go out into the world and then develop relationships with other safe adults. Without that first safe person, they don't know that anybody in the world is safe. And that's where that insecure attachment comes from. Okay, another question. Unsure, unaware of the trauma that they've been through. Ooh, okay. In that instance, so I have, quite a few cases that are teenagers and teenagers most likely don't want to talk with you at all. In that instance, I would not interview the child to necessarily learn more about possible traumas. I would more look for contextual clues. What maybe largely was their life like? So not, looking for specific traumas, but did you move around a lot? Tell me about things that you would do with your parents. Were your parents in the home? Who were your caregivers? Were they there often? Were they not there? And that's where you're going to be looking for more of those small T traumas, attachment disruptions, those small kind of pervasive disruptions that maybe don't seem like something that a teenager, for example, would identify as a trauma, but we know, looking at developmental trauma, that that's really significantly impactful. Okay, sorry. Trauma of change in caregivers as a trauma. Oh, yeah. Clients with multiple foster homes, that's a challenge. We know that children have significant numbers of placements throughout their time in foster care. And that's specifically a question where Dr. Bruce Perry's work with his neurosequential model of therapeutics really is beneficial. And I would highly recommend, again, that's linked in my references at the end, the neurosequential model, really looks at not just what traumas occurred, which is very, very important, right? The ages and traumas that occur, but also looking at what were some mitigating factors. So for example, for the children who have had multiple foster homes, absolutely each one of those disruptions is a trauma, absolutely an attachment trauma. However, did they have maybe the same teacher at school, for example? That could be a protective factor in a secure individual that can move forward. Did they have ongoing contact, for example, with a foster parent? For example, some of my foster children, when they've been reunified, we've continued providing babysitting support, for example. So that's a way, right? So that was still an attachment trauma, a disruption, but we could mitigate that. So that's the other piece of a conversation to have, and building resiliency, that again could be like a third training that we could do after this. So absolutely that would be a trauma, and then there's more information that we would want to know about that. I did get a direct chat as well. Let me check the time. Okay, we're doing good. I have read that trauma can be passed on through birth. Can you touch on this, is the question. Absolutely. So generational trauma is significant, and in terms of being passed on through birth, what that would be is, what were the stressors that the mother was experiencing during that time? Was she experiencing significant trauma? If she was, we know that there's physical trauma responses such as increased stress hormones, increased heart rate, physical dysregulation. So anything then that the mother experiences, the child in utero is also experiencing those changes in regulation and those increase in stress hormones. There's also the risk, for example, of actual physical injury in utero if it's domestic violence. The birth as well, was the birth traumatic? Again, there's a whole separate conversation about perinatal mental health, maternal health. How are we supporting mothers in their birthing experience, and what then does that look like for the child, the mother-child bonding afterwards? Absolutely. Okay, a 9-year-old child with OCD that was only related to trauma, she would check repeatedly. Oh, OCD is a difficult diagnosis to treat, but is also really fascinating from a research perspective and a neurobiology perspective, when you apply learning theory and trauma theory, and how those behaviors would be reinforced, right? So for example, for that 9-year-old child, she's checking the door every night for her abusive father, and making sure that he's not coming. And then every time she checks the door and he doesn't come, that's reinforcing the fact that she on her own is keeping her family safe. That poor baby. So I would also argue, in addition to OCD, she likely has a trauma diagnosis. In OCD, you would want to be looking at some additional symptomology. What behaviors do you need to be addressing? But that's again, that's something that isn't captured in the current trauma diagnoses, but is absolutely clearly a trauma symptom. So that complex trauma, that's what we would want to be looking at, and how is that carrying over for her into other settings. I'll take just a few more, because there is another conversation discussion that I'd like to have. Juveniles who've experienced trauma. Okay, so suggestions on how to balance opportunities for self-regulation and appropriate consequences. That is something that we'll talk a lot more about. The second hour is really intended to look at treatment and systems of care. But I will say that that's a challenge. So how do you teach a juvenile, right, who I'm going to go ahead and assume in this instance, normally shouldn't, but I'm going to go ahead and guess that they have significant complex trauma. How do you learn to regulate and self-regulate if no one has ever taught you that you can be regulated? How do you learn about appropriate consequences when nobody has ever demonstrated or modeled that for you? So I would argue that in order for the child or the juvenile to learn that, we first have to demonstrate that and create an environment for co-engagement and co-regulation. So I'll circle back to that. Gina Roberts, if you could make sure to bring that back up, we're going to talk more about trauma and systems of care in the second half of the presentation, and that's a great example. Generalized anxiety, yes. Okay, so this is a great question to end on. So how to approach teenagers to establish trust, to understand their traumatic experiences if they're reluctant to speak. Spend as much time as you need and are able, depending on your role and things like insurance companies, building that rapport, building that attachment. You may be the first person that they are able to establish a secure attachment with. You can be their attachment figure. I would really look at more alternative, right, approaches than just the traditional talk therapy. Again, we'll talk more about some different things. Finding ways to engage with them. What are their interests? What are their things that they really enjoy? Can you engage with them? Can you incorporate that into therapy? More alternative treatments like experiential therapy, animal-assisted therapy, things like that, to just even establish safety, right? And that's challenging. When they have had a whole lifetime without safety and trust, how do you develop that with somebody that you only see for an hour a week, for example? So spend as much time as you need building that secure attachment, building that safe space, right? Number one priority is increasing felt safety in that instance. Great questions, great conversations. Thank you so much, everyone. So this is a case example that we're going to be continuing to talk about throughout the day today. So our friend Robert, our little friend Robert, he has been involved in the foster care system since the age of 3 years old, when his father killed his mother in a domestic violence incident and was later incarcerated for this crime. Robert was exposed to significant neglect, parental substance use, domestic violence prior to his placement in foster care, with the suspicion of physical abuse as well. Robert was initially placed with several family members. However, due to concerns with each placement, Robert was removed from each home and eventually placed in traditional foster care. Robert is now 7 years old and placed in his 5th traditional foster home. Robert does not respond to his foster parents' attempts to engage him in family rituals and refuses any nurturing behavior, including touch. Robert can be aggressive and defiant, often blaming others for his actions, and demonstrates a significant lack of empathy for others. At school, Robert engages in defiant and disruptive behaviors during class transitions and is highly reactive to perceived triggers. All right, I would love to hear some thoughts about how this case, one, demonstrates the challenges that we've talked about in terms of diagnosing trauma for children. And curious, what are some of your initial thoughts about his presentation? And also, I want to acknowledge that your answers may vary depending on your role in this hypothetical child's treatment team. We're not really looking to diagnose him. Of course, you'd want to spend much more time to do that, but really I want to use this to really demonstrate some of those challenges that we've talked about today. You can put them in the chat, and also feel free to unmute if you feel comfortable. So the diagnosis could also be RAD, but I would challenge you a little bit, RAD in addition to trauma, not opposed to trauma. What we want to be thinking about, especially with complex developmental trauma, is what is driving all of this. If we look at RAD as just, he cannot form attachment, that's true, that's accurate, right? I described that in there. But what is driving that? Why does he not have the capability to establish secure attachments? Learned that violence is okay response. You're right, we don't know what his early childhood was, and that's a big challenge, right? So depending on your role or when you meet this child, throughout his journey through the foster care system may not. Oh, was that somebody chiming in? Okay, no consistency in caregivers, never learned how to regulate. Complexity, yes, due to those early trauma exposures and his subsequent behaviors. No attachment, cannot get hurt, no trust. No longer wants to try to create, yes. Oh, okay. Kathy Welch, you nailed it. He is 7, but developmentally he is 3 or younger. Absolutely, you are right. Treatment needs to work at his developmental level. Thank you so much for pulling that out. That's the big piece here. All of this is happening due to developmental stages and developmental process is constantly being disrupted. Thank you, Gina. Beverly, big challenge is that continuum of care. That's something that we'll talk about a little bit. He was used to the violence, hiding vulnerability behind his behavior issues. Absolutely. Suspicion of abuse. Yes, let's see. Okay, so a lot of discussion of his attachment and lack of trust. Oh, somebody else mentioned has never been able to learn how to regulate, and that's important, right? Thinking about to those prior questions about the juveniles in a secure facility, how do they learn how to regulate, right? If we have never taught these children that they can regulate, how can they learn these skills independently, right? We would never expect a 2-year-old or a 3-year-old to be able to self-regulate, right? We know that they need help, that they don't even have words to express themselves. So then why would we expect a 7-year-old who's developmentally 3 to be able to do those things independently? Yep, he needs assistance to navigate his world, no trust, consistency, lack of safety network, absolutely. Well, so that's an interesting statement of he never received the proper nurturing in his home because he is not receptive to it. I would reframe that a little bit. I would say that it doesn't feel safe to him. He's not receptive to it because his previous attachment figures were unsafe. And that's a challenge because as a foster parent myself, for example, right, and being able to engage with a child, you want that mutual engagement. You want to be able to enjoy the child and have the child experience being enjoyed. But if they're not receptive to it, right, that's very difficult. But so not being receptive to it is the behavior, is the trauma symptom, but we want to be looking at what's driving that behavior, what's behind that. Why is he not receptive to it? When we're changing how we're asking these questions and really considering that developmental piece, that changes our response, right? Because on the one hand, you have a child who's labeled, he cannot form attachments, he's not receptive to nurturing care, right? How challenging would that be to have that in a description and be calling as a caseworker saying, could you take placement of this child? He's not receptive to care. But if you change that and say, he's really struggles, he's not had safe, secure attachments, we're working to teach him and develop those safe, secure attachments. That's a very, very different conversation. And again, that's the need for an understanding of developmental complex trauma, and really being able to keep that in mind and shifting, right? Shifting how we're looking at these children so that we can really appropriately engage and treat them. He could also use encouragement of self-value. Absolutely, that's one that's often missed, right? A child, in order to have the sense of confidence to move through the world, he needs to know that he's important. And how do we learn that we're important? Parallel play, yes, that can be used by caregivers to give him safety. Absolutely. So something even like filial therapy, child-centered play therapy. Those are some treatments that we're going to be looking at in the second half. So that's a really, really important piece. And again, right, you're talking about age 3. So that's important because we know on paper, he's 7 years old, but developmentally, he's really 3. Okay, so it can absolutely vary in each childbirth order, siblings having different responses, absolutely. So that's a really great kind of connection back to that initial point when we were discussing the definition of trauma, right? We need to keep in mind what was the individual's experience, right? So say, for example, Robert has a twin brother. Their experiences may have been completely different. So as we're establishing, a treatment plan, a system of care for Robert and his brother, his twin brother, hypothetically, we cannot assume that what would work for Robert is also then what his brother would need. Absolutely, that's a really great point. Okay. Any final thoughts on trauma diagnosing, our friend Robert that we're going to talk more about? Thank you everyone for putting your thoughts into the chat. I apologize if I missed anyone, but I'm really excited that this is working so well. Oh, comments on sensory versus trauma. That's an important. So Al Miller says his basic needs as an infant were not met, likely issues. We need to build up the system around him. Absolutely. So that also connects, Alyssa, to your comment on sensory versus trauma. So again, I would say that it's not verse, right? So this idea of complex developmental trauma is comprehensive, and that includes space for conversation about sensory processing disorder. We do know that children who have experienced significant trauma often have significant difficulty with sensory processing disorders. So again, think back to an example of a toddler or an infant even, right? Regulation, sensory rocking, right? We rock an infant. An infant is rocked in utero. If they don't have that, that's bilateral stimulation as well. How does that impact their sensory input as well, right? Swaddling, being held closely, a lack of that. How does that impact sensory processing? What were their sensory input and early sensory input, and how was that mitigated by any protective factors? But because they do include significant sensory processing challenges, we should also be looking at that and automatically including referrals for occupational therapy in an example like this. Since complex trauma is not a diagnosis, how can your diagnosis for Billing reflect his needs? So in this, that's sort of the $1 million question, and that is never not a frustration of mine, to be completely honest. There's for Robert, there's a couple of options. In this instance, he would meet diagnostic criteria for reactive attachment disorder. So that would be a likely diagnosis that you could bill for, and then within that, understand that you're really treating complex developmental trauma. There's also a diagnosis in this instance, an adjustment disorder, because he was recently placed in a new traditional foster home. That is an ongoing trauma exposure and a recent trauma exposure that he is absolutely going to be having difficulty adjusting to, because who wouldn't? So that, there's sort of a bad joke that everybody can have an adjustment disorder diagnosis, which really demonstrates the need for better diagnoses. Felicia, in this example, yes, English is his first language. But that's an important question, right? So how can you engage in caregivers without being able to verbally engage? If for example, there's a difference in language spoken, which again, connects back to that understanding of complex trauma that allows for a conversation of cultural trauma, right? How impactful would it be to not just be removed from your family of origin, but also your culture of origin, your language of origin, and placed in a completely new setting? That's a huge trauma that, PTSD is not going to capture that, because that's not really a threat to one's safety necessarily, but it is hugely impactful. Pause for any final thoughts or questions. Okay, I think that might have been all. Thank you again for joining in on that discussion. So let's move forward. So now what, right? So now say we know we can understand and really demonstrate this complex system or complex trauma, how do we have a system of care that appropriately responds to those children? Oh, I think I saw one last chat come in. Oh, reassurance is absolutely going to be needed because of ongoing fear. Yeah, that's that kind of constant need is a challenge for children who've experienced complex trauma. So to begin with, let's start by discussing the traditional treatment paradigm and why that's a challenge. So, you know, traditionally when a child has, or historically, right, traditional treatments, right, we talk about skill building. So for example, cognitive behavioral therapy, right? Really focused on skills. What is that thought? Let's challenge it. Let's talk about those connections, right? We need to look deeper for children who have experienced complex trauma. The traditional treatment paradigm, traditional responses to children is very pathology driven, right? We're looking at stopping that thought, stopping that behavior. It just really is addressing the pathology of the situation, not what is causing the behavior. I've said several times already today, what's driving that behavior? What's behind it? Because we know that it's the developmental trauma behind those behaviors. Unfortunately, traditional treatment can also be very punitive in nature, right? If we talk about the lack of progress, needing to discharge a client from lack of progress or continuing behaviors, right? That's a very traditional approach. For example, the teenager, that was the question asked about, how do you build that trust, right? So in a traditional treatment paradigm, that teenager who has a hard time engaging could look non-compliant, right? Could look like they're not fully engaging. But when we apply the lens of complex trauma, complex developmental trauma, we can understand that what's really driving that is a lack of safe, secure attachment. Of course, they're not going to engage right away. That looks very different. The traditional treatment paradigm is also a very siloed treatment approach. The child carries the burden of healing and recovery, right? Because they need to learn skills independently, right? We need to get them to sit in their seat at school. And it's a very siloed kind of separate. The child is here, the school is here, the family is over here. But we need to really create a comprehensive approach and more secure environment for these children. Traditionally, treatment also focuses on very individual services, right? Okay, well, we're going to go over here for mental health, over here maybe for OT. But if we can bring this really comprehensive approach in, then we can also affect and treat this comprehensive impact of developmental trauma. And again, traditional treatment, as it stands right now, does not always appropriately recognize or address the impact of developmental trauma. So then what? Well, we've been shifting as a field to more trauma-informed care. In the last 10 years, even, I would say there's been significant changes, right? When I was in graduate school, the conversation was there's a trauma certificate, right? Trauma was separate. Trauma was a separate thing. And now we've moved to a space where we know trauma needs to be part of every conversation. But that's a really new development. Our changes in trauma awareness and understanding over the past 20 to 40 years has been significant. You know, the trauma distinctions were not even their own diagnostic category until 2013. And that's a very recent history. This goes along with our advances in understanding neurobiology, psychological processes, and the impact of trauma over the lifespan. Again, that's coming from SAMHSA. And they founded their National Child Traumatic Stress Initiative in 2011. Again, this is very recent history. So I think that's important to mention because we're still really in the beginning of establishing trauma-informed systems of care, which is why you're all here today. There's also increased access to evidence-based treatments recently. And efforts from a lot of different agencies and schools to adapt a more trauma-informed lens as a part of a system of care. And as we're doing that, we're also able to now shift the focus to healing and recovery. Okay, I see that there's a question in the chat. Working with a teenager that has had complex trauma and her behaviors similar to non-compliance, yes. Oh, only evident when she's with her mother and not others. I'm gonna try to come back to that question. Let's talk about the system of care and treatment options, and then we'll come back. That's a great case example. Okay, so when we're working to have a trauma-informed care lens, right? This is just even the lens that we move forward and talk about our system of care. So you heard me do this a little bit as we were going through our chat and our conversations. We're reframing how we're looking at these children and their behaviors. We're looking at not from their bad. Oh, Claudia, I love that your library is shifting that as well. That's very important. We're shifting to recognizing that okay, these were survival skills. They're maladaptive, sure, in normal society, but you're a survivor, and we're really changing that. We're working to provide opportunities for clients to heal from their trauma. And if we're doing this, if we're really going to accurately and appropriately address what's driving all of these behaviors and symptomology, we're really going to be investing in our clients, in our neighborhoods, our communities. We're eventually going to be saving money long-term, right? Because we talk about often, for example, breaking the cycle of violence, generational trauma, breaking that. How do we do that? Well, this is how. We really look at what is driving all of that, what is behind all of that. And then we also are starting to provide more evidence-based trauma-specific treatments. So this is a heavy information slide, but I included this because this is SAMHSA's specific guidelines for trauma-informed approaches. And again, I link that at the end. But this is a really great guideline that you could utilize, and you can find it. It's for free on the internet, and you can bring this back to your agency to say, let's use this to guide our conversation about our approach. So SAMHSA defines a trauma-informed approach is inclusive of trauma-specific interventions, whether assessment, treatment, or recovery supports, and yet it also incorporates key trauma principles into the organizational culture. So this was established in 2014, and they identify 4 key assumptions in a trauma-informed approach: realizing the widespread impact of trauma. Again, impact of trauma, when we're talking about children, that's the impact of complex developmental trauma, right? This is important, that impact, not just what happened, but the impact. Recognize the signs and symptoms of trauma in clients, families, and staff. That's another important piece. Our own vicarious trauma. We respond by fully integrating knowledge about trauma into policies. So Claudia, you mentioned your library. That's where this comes in. And we seek to actively resist re-traumatization. So for example, in a foster care agency, we really work to provide supports for a child in their current placement to minimize disruptions. And then there's 6 key principles of a trauma-informed approach that SAMHSA identified, which were kind of alluded to in my trauma-informed lens discussion, right? But they seek to establish safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and again, considering cultural, historical, and gender issues and impact, which again brings us back to we need to really have a comprehensive understanding of any factor, any source of traumatic stress for the children that we're working with. I know that this is a really kind of vague slide in a way or abstract rather, but I wanted to have that out there again so that you can use that as a resource. Heather asked, what does it look like for leaders providing organizational structure to combat staff trauma and work-related stress? Whew, that's okay. Billy, I hope you're taking notes about the list of trainings that maybe we need to provide. What does it look like? Gosh, that's a whole other conversation. So staff trauma, work-related stress, thinking about mitigating factors, the same way that we think about protective mitigating factors for the children. we need to think about that for our staff as well. So if we're asking our staff to work with children or families who have experienced high levels of trauma, are we providing them the appropriate tools to do so? Are we training them in evidence-based practices so that they can feel confident in the services that they're providing? Are we being mindful of caseloads? Are we being mindful of expectations of staff? Are we putting any other mitigating supports in? That's a whole conversation to have. That's a great question. There's also a question of being able to see the slides. I believe you should be able to. I apologize if you're not able to. Is anybody else having difficulty seeing the slides?
I can see them. I think they're having a technical difficulty. I'm trying to help them with that.
Okay, thank you, Billy. Sorry that you're not able to see that, but again, so it's SAMHSA, SAMHSA, and you can Google, if you Google that and trauma-informed approach, this is a PDF document that you should be able to pull up independently. So SAMHSA mentioned, right, that need for trauma-specific treatments, and that's an important distinction. So the other piece that I have personally seen is there's a lot of great discussion about trauma, very, very important, but then what? How are we treating their trauma, or are we continuing to be stuck in that traditional treatment paradigm? Without trauma-specific treatment, children are at risk of developing additional future problems. We know from the ACEs study, the Adverse Childhood Experiences study, that for every ACE score, they're going to be at higher risk for future problems such as substance abuse problems, high-risk behaviors, additional diagnoses. So how are we appropriately addressing that? There is also a difference between trauma-informed care and trauma-specific treatment. So for example, it was mentioned creating procedures and policies at a library that is trauma-informed. That's huge, right? That's very, very important. But then for mental health professionals specifically, are you providing trauma-specific treatments? That's very different, but a very, very important piece of trauma-informed care. Trauma-specific treatments directly address the trauma, right? Instead of the behaviors, what's driving the behaviors and the impact that has had on the client. This is where we're really going to facilitate that recovery from trauma and healing. And this is when we should be using evidence-based practices that have been proven to appropriately address and significantly improve trauma-related symptoms. Unfortunately, this is a barrier. That's something we'll talk about because trauma-specific treatments is a bit of a specialty, right? It does require a certain level of training, competency, and supervision ongoing to really ensure the efficacy of that treatment provided. Let me take a quick break to chat in here. Okay. I do not have a link immediately available for the ACEs. I believe actually you can find the basic ACE questionnaire online, but yeah, Billy, we can coordinate that afterwards. I believe also the NCTSN, the National Child Traumatic Stress Network, which again, I link at the end of this presentation, does have links and resources about the history of trauma, different trauma treatments, and that would be a place I would look as well. Ooh, where do you start to become a trauma certified clinician? I would say that today is a great start. So it does begin with being a trauma-informed provider. The NCTSN does have links to those evidence-based treatments and trauma-specific treatments, and that's then where I would start to move forward from. So we'll talk in a minute about more evidence-based trauma treatments, and we'll have a bit more of that discussion of traumas, how to become trauma certified. Each model kind of has their own procedure. Okay, so again, this is just to really drive home the importance of trauma-specific treatments. I apologize, this is a very heavy slide. NCTSN didn't really have a great way to trim that down, but that link at the bottom, that will take you directly to the NCTSN's description of these different trauma treatments. But it's important to have this conversation. Why do we need trauma-specific treatments? Well, like we've discussed, right? We need to have a better understanding of developmental and complex traumas to begin. And then we need to move beyond pathologizing their trauma responses, right? We cannot just look at the symptomology and behaviors alone. We need to be looking at what's driving that. So specifically, trauma treatments that have been found to be evidence-based and are recommended by the NCTSN include systematic assessment and treatment planning, addressing any barriers, and really provide psychoeducation to, depending on the age and appropriateness of the child, but about trauma reminders, right? Teaching about what's happened to them, teaching about them about the impact of the brain, on the brain, for example. Teaching emotional regulation skills, but in a way that is through mutual engagement in co-regulation, right? Learning more appropriate adaptive routines, parenting skills and behavior management. I don't want to minimize that. I oftentimes working with parents and foster parents, it can feel as though we may be excusing in a way some of the behaviors that occur. And that's not my intention, right? A lot of these maladaptive behaviors are not acceptable behaviors. But what I am saying is that we need to make sure that we're treating what's driving them those behaviors. What trigger led to that behavior? What trauma response is occurring? Because if we're not really looking at that, we're going to miss that opportunity to really improve those relationships and child behaviors. Oftentimes constructing a trauma narrative is a piece of trauma that can look like a lot of different things. And again, I'll talk more about that when we discuss the different treatment models. There's also a way to monitor client progress and response in treatment, but in a trauma-informed way, right? Again, we've talked about traditional treatment can be very pathologizing and very compliance-driven and punitive, and that's not what we're looking for here. And then again, we're looking and evaluating for effectiveness. So these are some. Oh, thank you, Melissa, for sharing that resource. Oh, yes, Alyssa, it is so difficult when the context of trauma remains, and then the school is about behavior management. Absolutely. So let's talk about that a little bit. So here are some. This is not in any way a comprehensive list of evidence-based trauma treatments at all. But let's start with this conversation, and then we'll go back to some of those comments in the chat. So there's play-based interventions. I'm currently working on my registered play therapist certification, supervision and additional trainings. But play is really, really great because, again, let's think back to our friend Robert, right? We've identified him as being 7 years old, but developmentally he's 3. What do 3-year-olds love to do? How do 3-year-olds learn about their world? Through play, right? So interventions such as sand tray therapy, theraplay, and child-centered play therapy are really, really incredibly beneficial. So within each of those, between sand tray and child-centered play therapy, for example, there is a bit of an opportunity to create and explore trauma narratives in particular. So for child-centered play therapy, as you support them and work them through that model, they may get to that mastery stage and begin playing out or taking mastery over their own experiences. I recently had a child do that. They reached they're in the mastery level of child-centered play therapy, and they're beginning to bring in on their own aspects of their trauma experiences into their play dynamics. So that's a trauma narrative based on their own, this child is only 4, right? So you're not going to be sitting down and creating a structured story necessarily, but again, that's their version of a narrative, similar to sand tray therapy. We talked a bit about the sensory processing challenges. Sand tray therapy is an incredible intervention for children who've experienced trauma. There's a sensory experience, right, of the sand, or depending on what sand or kinetic sand, maybe even beans or rice, right? But that sensory experience of moving it around, choosing which figurines to include in the sand tray, getting up and walking over, getting up and walking back, right? Bilateral stimulation, that's very regulated. If they just need to take a break and move around in the sand, sensory regulation at work. TheraPlay is an incredible intervention. And there was a question about working with juveniles, right, in a secure facility. TheraPlay is actually a way that you could have an identified staff person, not the clinician, but an identified staff person acting as that child's caregiver figure, right, to explore and experience the secure attachment. So TheraPlay is an attachment-focused, play-based intervention that sort of looks at how to recreate a typical development and those typical experiences throughout a lifespan, but in kind of a structured way that has specific activities and play activities that you would do and facilitate between the child and their caregiver, that mimics that experience of, for example, an infant, right, of being held, and the infant is the only thing that matters in the world for that parent and child, right? And just being the center of their world. TheraPlay kind of creates opportunities for those same experiences to occur for a child who has missed that. Trauma-informed expressive arts, absolutely. I cannot speak to the research on that, but generally any way that a child in particular can express, you know, their impact or their understanding in a safe way, it is really beneficial. Generally speaking, it's some of the really traditional talk therapies, right, that don't necessarily work, because how do you sit down and just talk about, you know, okay, I've got to change this thought. Okay, well, what core belief led to that thought? You know, how can you, if you do not believe that you are a child worth loving, somebody has to love you first. So I've done a lot of art activities. I'm not an art therapist, but that absolutely would be worth exploring. Then there was a question earlier about being a certified trauma therapist. So that's where you get into then the different models. So there are a lot of trainings out there that I have seen of trauma certification or certified this. Really what you want to be looking at is what is the actual model that they're utilizing, and is that truly identified as an evidence-based treatment? So that's where I go back to the NCTSN. Again, I linked that there. They have intervention fact sheets, and I would really want to be looking at what is the training being offered, what is the treatment being described, and is it truly evidence-based? So trauma-focused cognitive behavioral therapy, there is a full structure to be certified in that model, including initial and online training, in-person training, ongoing consultation and supervision in the model, and then it culminates in a test. And also in case presentations as well. Similar child-parent psychotherapy, there's in-person trainings, continued trainings, and then ongoing consultation and case presentations. Trauma systems therapy, parent-child interaction therapy, same things, right? In-person trainings, which has been a big challenge during COVID. But the main point here is that it involves training and then ongoing supervision. And then there was also that question earlier of how can leaders and agencies support their staff and mitigating staff. That ongoing supervision is a huge piece. So are you trained as an agency or a facility? Are you training not just your staff in these models, but are you either one, providing ongoing supervision specific to that model, or are you also training your supervisors in those models so that they can provide that ongoing support and supervision, reflective supervision, right? It's really, again, the idea is comprehensive and fully looking at that. Yoga as a way to regulate emotions and body mastery. I have seen trainings about yoga, and I have incorporated, I want to be clear, I'm not a yoga teacher, I'm not trained in that, but I have, you can purchase these on Amazon. I don't have them handy, but yoga pretzels, I'll put that in the chat, yoga pretzels. Let me make sure I'm not responding to somebody individually. Sent to everyone. Yoga pretzels cards. They're super fun. And it comes in a set, and there's breath work cards. There's different poses that you can do and engage with the child. There's some mindfulness activities. Absolutely. Again, I would say it should be within the context of a secure attachment, whether that is with you as a clinician or you're engaging the caregivers, whatever structure is in place. That's a great one to do at school as well, right? Teachers, are they taking a brain break? That's great. Let's do something that is regulating. There's also down and up regulating activities, which is a piece that, again, whole other conversation, right, about trauma symptoms and trauma regulation. But so there are some poses in that yoga pretzels that are upregulating, so more active poses, right? The child may have to work a little bit more, but there's also some down-regulating breathing activities in there too. Excuse me, and yoga also in particular, that's a really great way to also increase self-awareness and body mastery. So we talked about, right, traditional treatment paradigm is a very siloed approach, right? But what we really need to be doing is incorporating physical therapy, occupational therapy, right? A child who's experienced significant trauma often has very little body mastery. My foster daughter in particular, if she gets excited, watch out, because no matter who is around her, they're likely to get like a hand to the face, a foot to the face, and it's purely accidental. She's not trying to knock over my toddler, but she's just so excited, and she has so little physical regulation and self-awareness, mastery over her body, that things kind of explode very, very quickly. So anything that you can kind of do to increase that self-awareness, right? Where is my body in space, in the room? That's really, really great. TheraPlay also does a great job of that as well, and consequences too, especially within the context of a relationship. So there's specific activities that the clinician structures accordingly. And so, the child may not want to do that. So how can they learn to be challenged and tolerate that challenge within the context of playing, of being in a secure, safe space with their caregiver? That's a really great, I think that was an earlier question. That's a really, really great one too. In terms of even just having frameworks to utilize and view your clients or your work through: attachment, self-regulation, and competence. That's the ARC framework. It's evidence-based and provides a lot of different suggestions and guidance in terms of caregiver involvement, caregiver affect regulation. And then the neurosequential model of therapeutics, that is Dr. Bruce Perry's framework, and that is an incredible process. I went through the initial stage of training for that, and the amount of information and understanding that you gain of neurobiology, of the impact of trauma at different stages, of the power of mitigating protective factors and to build resiliency. Really, really incredible. Oh, EMDR, that's one that I'm not personally trained in, but that is evidence-based. And there's a lot of work. I've been to a couple different, well, not recently because of COVID, but I've seen previous trainings about incorporating different play therapy models and EMDR. So that's a really, really great opportunity. Any questions? Again, discussion of evidence-based treatments. This was kind of a quick and dirty discussion. There's a lot more to talk about there. Ronnie, yes, do I recommend that? I actually happen to have, this was going to be part of my discussion at the end, but this is Dr. Bruce Perry's first book, The Boy Who Was Raised as a Dog. This is a fascinating read. I will say it is at times difficult to read, so be mindful of your own vicarious trauma, your own recent trauma exposures. But this really discusses what I was talking about the shifting in the field. This talks about his entire career of learning and working with children, right? Learning about how children can mitigate their own trauma exposures during play therapy, for example, right? If you allow the child to control the situation, like through child-centered play therapy, they may mitigate their own trauma exposures. Rocking, the need for that bilateral stimulation that can occur, for example, in fair play. He talks quite a lot about this. Each chapter is a case study, and it's a really, really incredible book. What happens to you? Full disclosure, I'm still in the process of reading it, but I absolutely would recommend, I mean, anything that Dr. Bruce Perry does is just an incredible resource. And actually for those in the Rockford area, I am going to be facilitating a conversation about this book through our Rockford Public Library in September, I believe. So yes, I would absolutely recommend reading these books. And anytime I hear Dr. Bruce Perry's name, I want to be there learning about it. He's an incredible, incredible resource. Any questions about these treatments? Again, I could go on for a full day about each of those different interventions. Oh, Dan Siegel is another really incredible resource. Rosalind asked about if I can explain trauma systems therapy a bit more. I actually cannot. That is one that I'm not personally trained in, but it is considered an evidence-based approach. So my very, very basic understanding is that it's really looking at so family systems and then systems of trauma impacting the child. Moving forward with that. So Dan Siegel is a really incredible resource. I actually have some of his books in the other room. He's really great. And one piece, so we talked a little bit about trauma treatments need to include psychoeducation and information provided about trauma symptoms. So neurobiology in particular is something that we need to be making sure that we're educating our children about as they're able to, as well as our caregivers. And Dan Siegel has a really great brain model, right? Where he talks about the lower part of your brain, the upper part of your brain, right? And how, the lower part of your brain is the survival, right? Source of all of your stress responses. And when you're triggered, when you're experiencing a trauma response, your brain flips. And that is a great way to explain, right? To a child who's experiencing active trauma symptoms, honey, your brain has flipped. You are not going to be able to sit and do math because you're coming in from a very traumatic experience in your family. It's a really, really helpful resource. So if you Google Dan Siegel brain model, the hand brain model, you'll be able to find that video. The Body Keeps the Score is also a really great resource by Bessel van der Kolk. That's an incredible one. Trauma and Recovery by Judith Herman is also another great resource. This is also another book that I grabbed that I'm making my way through, The Interpersonal Neurobiology of Play, just to really increase my understanding, in particular for play, right? As a child practitioner, play is the way that our children move through the world. Billy, can I maybe get you a list of some of these additional books and the resources that are linked? That's okay, all caps. If you're excited, Christine, that's okay.
Absolutely. If you get those to me, I'll share them in the follow-up email with the recording and slides.
Sure, that'd be great. Yeah, the books are wonderful. I will also, when I send them to Billy, I'll also include some of Dan Siegel's books as well. Okay, so I'm going to go ahead and move into our discussion about Robert. Okay, so I'll give everyone a minute to reread the discussion. Okay, Alyssa, I'll come back to that in 1 minute. So go ahead and reread our case study or information about Robert, and let's apply what we have talked about. So what might treatment have looked like, let's say 20 to 30 years ago in a more traditional treatment paradigm? What would some of those responses and systems have looked like for him? But now that we've talked about, what would the treatment response be with a more trauma-informed care approach? And then I do see the questions from Alyssa and Jennifer. I'll come back to both of those questions after we've kind of talked about this, because my answers are kind of tied to this shift here. Child conforms to the treatment versus treatment is based on the needs of the child. Absolutely. That's exactly it, right? This is a kid who in school, we have to get you in line, right? Other than looking at, why are you out of line? Why are you having a hard time? Does anyone else want to even chime in? Unmute yourselves if you want. About the differences between a traditional treatment approach and a more trauma-informed approach. Yep, positive, negative enforcement. Ah, yes, not just Robert in therapy, but his caregivers. Looking at the why of the behavior instead of trying to correct it. Absolutely. So then, for example, we did talk about, right, a couple people have asked when the family is the context and it is the source of traumatic stress. What is a caregiver, right? A caregiver can look at like a lot of different things. If you, for example, as the clinician in the school counselor, if you are his safe space, do you have a sandtray, for example, where he can come, put whatever he needs to in that sandtray, have it be safe and contained, and have that be the safe space to hold that as he moves back into school and through his system? Or can you really actively incorporate his family? And let's see, somebody said something about bringing in other care providers. Okay, lack of coordination. So absolutely, Maribel, that would have been a previous problem, and that is still a challenge today. But if we can really incorporate everybody, can we bring in additional service providers and meet those different needs? Calming corner, a calming space, that's really, really important, right? Having different sensory options there, recognizing that they need some space and having a safe person, minimizing barriers, individual needs. Okay, so what would you do when the source of trauma is family? It's a very heavy question, and I would say that it really depends on, what that trauma exposure really looks like, and also what is the context that you're working with the family, where is the family at? So is this, for example, a situation where you need to be making a hotline report? Is this a situation where you need to try to engage additional supports? Is there domestic violence? Do you need to be providing the mother or the father, depending on the scenario, with additional safety resources? So this is where, we want to be really looking at what additional mitigating factors do we need. Does the family need housing support? Does the family need assistance with utilities or food? Could that help remove some of the impact of that traumatic stress? Alternative caregiver or respite, absolutely. So that's something that we actively utilize in foster care, but that can still be, you know, in treatment or in a trauma-informed space, right? For a school example, can there be a coach who can be that one positive support figure that can fill that role? Absolutely. Let me see if I missed any other. Okay. Oh, traditional treatment approach can end up in a misdiagnosis, while trauma-informed approach will address the issues in its roots. Absolutely. You know, when I play around with the idea of going back for my PhD, that's one of my biggest research questions that I have, right? Do we have an accurate understanding of just how many children are misdiagnosed? Can we even have an accurate understanding of that right now, because we don't have an appropriate diagnosis, right? We don't have that diagnostic code that we need for developmental complex trauma. But Dr. Bruce Perry indicated that really what's driving and leading to a lot of those behaviors is trauma. And that's very, very different. Oh, family just labeled the kid as bad. Yes, right? There's so many times that trauma symptoms and trauma responses are labeled bad. They manipulate, they're needy, they're disruptive. Oh, Kate, yes. How many times have you just had a child say, Kate, you just need to fix it? Well, no, I can't, right? Because there's so much more going on here that we really need to have a big look at it. Over medication, that is a really tricky one. And actually, medication, for those inclined and curious about that, that's a big discussion that Dr. Bruce Perry has in this. So there are some things, some symptomologies that can benefit from medication. So I don't want to disparage medication. That has a very important role in treatment. However, if you're misdiagnosing, if you're not appropriately considering complex trauma, if a child with a trauma history just went to their pediatrician and was diagnosed with ADHD and given medication, that is a big, big problem, right? Medicating ADHD versus medicating hyperactivity as a trauma symptom is very, very different. And we also know that medication should not be a standalone treatment, right? Again, if we're trying to have comprehensive care for this comprehensive understanding of trauma, we need to be coordinating. We need to be having medication management in addition to treatment. I don't know if developmental trauma will be included. I am very hopeful that it will be, because we really need to do better for these kids. Any other questions specific or thoughts specific to Robert? Absolutely. This trauma-informed approach really looks at the big picture of the child and really looks at the environment and all needs. And it's really, really important. And it really, again, is an active model. It's an active way to approach care as well. You heard me challenge, and reframe a couple phrases. And that's not to say that anybody's, initial conceptualization of Robert's presentation, for example, or trauma was wrong. But if we reframe it, right, if we're actively putting any symptom, any presentation, any behavior within the context of childhood developmental trauma, that really shifts how we're able to look at the needs of the child and meet them more appropriately. So let me move forward and So let's talk about some of the barriers to implementing trauma-informed care, and then I'm going to circle back to some of the earlier questions. So trainings, right? Limited funding for trainings, for ongoing supervision. I work at a nonprofit, right? We know that at nonprofits, we have to beg, borrow, and steal for funding. So what can we do? We also have limited service providers. I don't know about everybody else, but in our area in particular, we just have wait lists for any service, occupational therapy, physical therapy, mental health treatment, and we just cannot hire enough people to keep up. And then the mental health providers that we do have are very overburdened, right? It is very, very heavy work to do this work, to really engage with these families, it is heavy. So if we're not considering that, and we're not managing our expectations of staff, for example, as leaders, we need to do a better job of that. The other thing that, again, we talked about the traditional treatment framework of being more punitive in nature, but systems in general, the systems that we tend to work in as providers for children are very punitive. Foster care in general is very punitive, right? The parents make a mistake, you lose your visits. Parents are having a hard time. They're trying to recover from their own generational traumas, right? They've had their child removed. And we have to do that, right, to maintain safety. Sometimes schools may have to do that as well, suspensions, expulsions to maintain safety. But so then we need to be looking at these symptoms and be thinking, what other mitigating factors, what other supports, what other trauma-informed systems can we put in place to try to prevent and be proactive instead of reactive? Looking at participation requirements, for example, those are inherently ableist. Cancellation policies, that's a big challenge. So we need to be having these conversations to be mindful of all those things. So I'm going to try to go back and find the original question about, okay, so Alyssa asked comments on the efficacy of evidence-based training when the trauma context remains. So we would then be looking at resiliency theory and how to build resilience. So the context of trauma may remain, right? There's, caregiver substance abuse, for example. We may treat that, but then we know that parent is forever an addict. So how do we cope with that? So then we need to be looking at additional mitigating protective factors. Is there another caregiver that we can bring in? Can we build in additional supports around this, not just the child, but the family unit as well, and that caregiver to help prevent relapse, to provide additional neighborhood supports. And then Jennifer asked, sorry, my mouse is having a difficult time finding your, okay. What model would you recommend if you are new to trauma training? So I started specifically treating trauma through trauma-focused cognitive behavioral therapy. It is evidence-based. I have had great success treating children with a variety of experiences, from an acute traumatic car crash to sexual abuse to complex trauma and into lifetime in the child welfare system. There's a lot of value in it. I will say that provided a really strong introduction into trauma-specific treatments and really conceptualizing things in terms of the framework of TFCBT, in terms of psychoeducation, building in regulation skills. But I will also say that can sometimes lend itself to having a little bit more of a heavier burden on the child. And that also requires active cognitive processing, and not every child that has experienced trauma is able to do that. So for example, a child adopted at infancy, that's a trauma, right? We often talk about the positives of adoption, which is incredible in every way, but adoption comes out of trauma. So that's not really something that a child can sit down and cognitively process. But if we're looking at the impact of early developmental trauma, then we're leaning more towards play-based interventions. And I would say that at this point in my career, I tend to have a more child development attachment approach, and really lean towards my more play-based interventions for trauma treatment. But I would say, TFCBT is a strong intervention, and I would really depend on what population you work with. Okay, so Jennifer, I will come back to your question in a minute. Okay, so Melissa, speech language pathologist, new to mental health, the understanding of language development is very limited. have developmental language disorders. So actually my sister is an SLP, and we've had this conversation a lot. So you're absolutely right. So some children are not going to be able to engage in treatments because of language. Sorry. It seems my dog has identified a stranger. Sorry about that. But so yes, absolutely. So and in fact, Melissa, that tends to be why I'm leaning more towards play-based interventions, because you don't have to talk about, while you're playing, right? So in particular, I mentioned a child that is 4 years old, and I've been engaging through child-centered play therapy. They started to bring in a trauma narrative. This child was verbal, but was difficult to understand, right? That's a higher cognitive skill, right? And so if we're talking again about neurobiology, that brain development, that's not going to be the priority if they're in pure survival mode. And again, neurobiology and the impact of trauma on the brain, that's a whole separate conversation for ongoing training, but you're absolutely right. So that's such a higher kind of processing capability, a higher cognitive skill that's going to, if you're only focusing on interventions that utilize that, you're going to miss opportunities to provide effective trauma treatment. And again, same thing for our friend Robert, right? 7 years old, developmentally 3. That's not necessarily something that he's going to process and be able to verbally do that. Thank you so much, Ronnie. What other training would be good? A good complement that lessens the burden on the child. So caregiver support, I would say. So any way that you can provide caregiver support so that it's not just the child needing to learn these skills. So the ARC framework, for example, really does a lot of work around that caregiver engagement. And learning, helping the caregivers in particular learn how to co-regulate, manage their own stress responses, in addition to kind of looking to teach skills to the child. So for example, right, you might help the child learn how to identify basic emotions, but then you need to have that caregiver involvement so that in the moment when a child is having a meltdown, the caregiver is able to sit with them, stay present with them and say, you're having a really hard time. You're feeling really mad and scared right now. And I'm here with you, right? But that's also very, very difficult at times, right? With a very dysregulated child. So being able to really involve the caregivers. Yeah, they do need to be loved first. Absolutely. And that's actually something that, again, Dr. Bruce Perry talks about. He met a foster parent who would just rock her babies, right? Whether they were actual babies or they were just children in her home, they need to be loved first. They need to experience that, be delighted in, be enjoyed, learn that they are enjoyable. And that's a really, really difficult one. Absolutely, so many times a child is a targeted problem, right? So again, that's why I'm trying to model today, how do you challenge even just some behaviors and phrasing when we're discussing children and talking about that. Oh, Alyssa, yes, boundaries with service providers and touch in a school setting. That's a very difficult one. So TheraPlay is a model that does involve a lot of touch, but there's also a lot of really great ways to have engagement without touch. So for example, during a transition time from a child in school that was receiving separate I don't know, let's say speech therapy, for example. They had speech therapy and they're trying to get back to class. That's going to be a very difficult transition because they just had their own separate individual fun time, right? Maybe played some games, and they have to go back to class. It's going to be very, very difficult. Now, you cannot necessarily sit there, hug, right? Provide that physical connection, but what can you do? Can you do a high five? Can you engage in co-engagement, mutual engagement, and tiptoe like a mouse back to class? Is there a quiet song that you can sing? Twinkle, twinkle, right? That's co-regulation, bilateral stimulation, mutual engagement. Oh, this is my special thing that I do. Establishing routines and rituals, doing the same thing, the same time every day with a child, that creates that same sense of experience of that physical nurturing when you maybe are not able to do that. Give a hug stuffed animal, absolutely, right? Something, again, that sensory processing piece comes in too, right? Being able to hug and squeeze that. Okay, let's see. Yeah, the needs of the child just versus switching. Oh, felt strips. Yes. So there's a lot of really, really fascinating sensory processing things. And again, you want to be looking, what are the needs of that child? Do they need upregulating activities or do they need downregulating activities? And what does that really look like? To be mindful of time, we do have some time to continue this conversation a little bit, but I want to end on how do we move forward with trauma-informed care? What does that really look like? Well, I hope I've gotten you excited about really challenging and advocating for children that you work with, really actively seeking to reframe them and their behaviors and view them within the context of their trauma histories. Some things that you can do for yourself: seek out trauma-specific trainings, apply for grants, for example, for trainings in evidence-based treatments, advocate for those additional opportunities with your employer. If you are an employer or a leader, make sure that you're advocating for that for your staff. If you are in a situation where you're not able to do that, or maybe your role is more a case management piece, make sure that you're referring clients for trauma-specific treatments. And then when you're coordinating that care, really evaluate, are they truly receiving trauma-specific treatments? Look within the treatment plans, look within the goals or the reports for questions. Do they list a specific evidence-based trauma treatment? Are they even specifically mentioning, we're in the core intervention phase of child-parent psychotherapy, the stress management module, TFCBT? Are they actively utilizing those frameworks? And above all else, if nothing else, be the person that can hold this child's trauma history in mind. Be the person to say, hold on, let's take a moment, let's think, what is driving this behavior? What need is this child trying to meet and fill? Really encourage deeper conversations about those responses, those behaviors, what's driving that, and then try to establish more attachment-based responses. Have more proactive responses to mitigate any stressors, remove any triggers, right? We're so reactive as a society, but if we can shift that, be more proactive, really increase that sense of felt safety for our children, that makes a big difference. And now we're here. We've got about 13 minutes. I think I timed it okay. And let's see about any additional questions here. I'm so excited. Everyone has, I hope you've taken a lot out of this. Absolutely. Very important for school teachers to be trained in incorporating this. I've done a couple just basic trauma 101 trainings for our local schools here. Unfortunately, then there's additional barrier questions of how can our already overburdened education systems not just teach our children, but then also help mitigate trauma and mitigate all those stressors. So, right, we've talked about systems of care, and as we're being trauma-informed providers, we really need to consider that at every step. Can we be advocating for additional neighborhood resources? Asking that of our policymakers as well. There's a question to me, is there a difference in the boy who was raised like a dog regarding the one that you showed and the one with blue cover? So this one is so the boy who was raised like a dog, this is very specific treatment discussions and discussions of his development of his understanding of child trauma. This one, I'm getting into it, but this one is a little bit more of deeper personal conversations, is my understanding, conversations about more of the impact of trauma and also resilience and healing. So also, I think my understanding is this is sort of his initial work, and then this is, right, making meaning of all of those experiences. How can our physical environments be trauma informed? So sensory processing is a big one, right? So are they very loud, or are they quiet? Do you have loud, bright colors, or do you have, is it a more soothing space, right? Do you have, if you're in a school, they talked about calming corners, and being able to go back to those spaces, right? That's an important piece. Oh, I'm sorry, here we go. There was a question I needed to circle back to. Okay, so question about why the teen is displaying behavior only while with the mom and not the others. That could truthfully go a couple different ways. So one thing that we know about secure attachments is that when there's felt safety, that also means that the child is able to show, their more vulnerable, hard sides, right? So that's often why, for example, my daughter might have really, really big feelings with me because she's 4, but also because I'm a safe space, right? She knows that I can safely hold those really big, mad, sad feelings when her, toddler brother breaks her toy that was so, so important, right? She knows that she can be really mad, be kind of explosive, right? She doesn't have to keep it all together because I'm her safe person. She doesn't engage in anything close to that at her daycare program. Not that they're not safe, right? But I am her very, very safe space. So it could be a piece of that, right? Does she feel safe with mom? And is that what's driving that? Where she can, she's kept it together, kept a lid on it, but that's the one place that she knows she doesn't have to? Or is mom the trigger? Is mom the source and representation of a lot of that traumatic stress that may be driving some behaviors? Is there unresolved attachment trauma there? Those are some questions that I would want to ask and really explore deeper for that piece. Links of resources, I'll work with Billy to try to get everything. Oh, you know what, let me go ahead. So I'll put this up on the slide as we're finishing these conversations. Here's some of the resources that I mentioned today. Yes, don't single out a child because they've been labeled to be bad. Don't do that. And challenge, challenge when that's occurring. What is the safest way to learn more about trauma experiences from clients without re-traumatizing? Oh, that is a great question. So it depends on your setting, and it depends sometimes as well on what you know about the referral, the child coming into your space. Unfortunately, there's been times where sometimes I've unintentionally triggered a child because a topic or trauma trigger came up that was not previously known. But so you do want to be mindful of that. So this sounds kind of silly, but I have seen it happen. But if you're completing an assessment, meet with the child, learn the child a little bit, get to see their initial presentation, schedule a separate session with the caregiver to talk about their understanding. Get releases for any other providers involved with the child in foster care, right? Get releases to be able to speak with the case manager and get additional sources of information to get a better picture. And don't have those conversations in front of the child either. And the other thing is that we can also, with the understanding of complex developmental trauma, and we're looking for those clues and indications that something has happened, right? We don't necessarily need to know the full picture or specifics to understand, okay, at this age, there was an attachment disruption. At this point, there was domestic violence or significant violence occurring in the community. Right now, right, over the last year, COVID has happened, right? So we don't necessarily need to know the specifics to know that's a significant trauma for a lot of our children. Thank you so much for everybody and your feedback. I'm so glad that this has been a beneficial training. What about having those conversations with youth and teens? ask them to tell you about their lives, right? For example, I myself, depending on the teenager, I have really had to acknowledge my own privilege before I'm able to have those conversations. So I need to acknowledge I am a white, cisgendered, heterosexual, female, upper class, to them anyways, right? So I need to acknowledge that my life has been very privileged, at least on the surface, in comparison to yours. I can't fully understand your story. Please tell me about it. What do you think I need to know about your life and your experiences? And again, continue to look for those clues, right? Those indications that there's been developmental trauma throughout their life. Thank you again, everyone. And again, I do want to kind of acknowledge and apologize for the brief overview of a lot of different aspects of trauma presentation, symptomology, diagnoses, treatments, right? That this could be a full week, you know, of trainings, but I really appreciate everyone's participation and conversations. And Billy, I'll hand it over.
Yeah, absolutely. Thank you so much. Trying to get I don't know if you can see me. I'm having trouble adjusting the view, but if not, you can at least hear me. I'm going to stop your screen sharing. Oh, here we are. That's great. I did drop the link for the evaluation in the chat. We've had a couple questions, so please look for it there. So thank you so much, Jessica. This session was absolutely fantastic, really enjoyable. We learned a lot, and thank you everyone for joining us today. I'm going to share a screen with information for you. So know that in regard to today's session, I'm going to send a follow-up email with any of the resources that we discussed in the chat or during the session. I'll send the session recording and a link to the evaluation form along with a copy of the PowerPoint slides. Watch for that from me by the end of the day tomorrow or by the next morning. The evaluation session or the evaluation for the session, you do have to complete that to share your information for CEUs or PDC credits. We do not have a certificate of attendance, but you can pull the Eventbrite description and your registration confirmation email. For those, that usually suffices. I know for me, for my nursing home administrator's license, so it should be a useful tool for you. So things that we have coming up, we had a session in June on cultural competency. So I know Jessica mentioned some things about that and recognizing our privilege and how that comes into play in our treatment environment. So if you'd like to watch the recording for that, you can find that on NICNE's YouTube channel. On August 10th, we have Kevin Polke, who is the founder and president of KP Counseling and the founder and executive director of Shatter Our Silence, a nonprofit working to help address suicide risk in youth. He's going to have a session on August 10th on resiliency development and the responses to the stress cycle. So we did cover a little bit of that today, but this session really is going to segue very nicely into that session. I will share the link for that. I did send it in the reminder email, and I'll share it again with you in the follow-up email. On September the 14th, Xavier Whitford, who is the executive director of the Tommy Carell Memorial Foundation and a board member of NAMI of Northern Illinois, and Kevin Polke will present a session on suicide prevention. I want to share a little more information with you about the work that we are doing in the Winnebago County and Boone County area of Northern Illinois. We are working on assessing and improving the youth mental health services system in our region. So we have a multi-year project that we've been working on. We're 3 years into the process already, and we anticipate that going on at least another 3 years before we hand that off into the community. But we have a survey that we've just opened. It's going to be open until July 27th. And we are asking if you have experience working with youth that live in Winnebago, Boone counties and have experience with youth mental health services, or if they lived in that area during the time of service, that you share this survey with them. I shared the link and the QR code is on the screen in the email with you yesterday. I'll share it again in the follow-up email tomorrow. But if you have access or work with youth or families or caregivers of youth that have received mental health services in Winnebago and Boone counties in Northern Illinois, please do take a moment to share that. We really want to get an accurate perspective of what people's experiences are. We're identifying gaps in the system, areas that need improvement, and trying to be a conduit to empower families and parents to help make change in the system that maybe hasn't worked for them. So a little more information about the group behind that process. we have a youth mental health system of care planning team that meets monthly. It's a group of representatives from area organizations and community groups working together to assess and plan for system improvement. And we also have a parent and family group that informs the larger planning groups process. So if you either are living in the area or have youth in the area that are your personal family members or yourself as a youth, and you want to be part of the YES team, please contact Pam or I about joining that. Or if you're a professional in Winnebago or Broome counties and would like to join the monthly meetings or be informed on what we're doing, please reach out to Pam or I and we will be sure to get you on that list. So with that, I want to thank everybody. It's 11 on the dot. We hope you have a fantastic rest of your day and thank you so much for joining us. Bye everyone, take care.
Thank you, everyone.